السلام عليكم. محاضرة رقم 5. So you can see that the lectures, some of them go over the 45 minute mark. So بالنهاية راح تلاقي إنه كل محاضراتنا will end up being يعني collectively together، لأنه في راح يكون آخر محاضرة تكون شوي قصيرة. So let's go. These are things that we went over last time. About cutaneous abscesses, and this is the collection of pus. Main point is that this is painful, tender. شو الفرق بين pain و tenderness? Pain is without touching, it elicits pain. Tender is when you touch it, it elicits pain. Fluctuant nodules, so it is not fixed to the underlying structures. This is something that is typical of an abscess. Why? Because obviously this is a collection of pus and fluid, and the outside borders and the walls of the abscess will not fix to surrounding structure. شو أشياء fixed? The most worrying thing that be fixed and who will? Yeah, مثلا lymph nodes or a cancer cells. This is what you worry about, is that they might be fixed and non-fluctuant ما بتحركوا. Usually with an overlying pustule اللي هو حكينا the head, and is surrounded by a rim of erythematous swelling. Treatment is a definitive treatment is the drainage, and then antibiotics are rarely necessary. تمام. Okay. هلا هاي المحاضرة أهم إشي فيها that we will cover is diabetic foot. And then after that we will cover the remainder of the skin infections. يعني راح ناخذ a representative of many different types of skin lesions. But diabetic foot is probably the most subject that contains everything. شو يعني? It means that almost many of the things that we will mention in this module as a microbiology, immunology, infectious causes, all of them will have a representative in diabetic foot. So you will see that lots of infections can be seen in diabetic foot, and understanding diabetic foot and probably it's the most major skin infection that you will deal with in the hospital setting, as well as in a clinical setting as well. فراح تشوف فيها paronychia, cellulitis, myositis, abscess formation, necrotizing fasciitis, septic arthritis, tendinitis, osteomyelitis. Everything can happen in the setting of diabetic foot. So what is diabetic foot? It's basically an infection in a patient with diabetes that is below the malleolus. تمام? Anything below the malleolus is called diabetic foot. The most common of these is an infected diabetic ulcer. However, as mentioned, it is a broad spectrum of infections ranging from all what we mentioned. So, what do we see here? Epidemiology. The foot infections in diabetes are one of the most common complications. Things that you worry about in diabetes actually هو بالنهاية it's a vascular neurological complications. All vascular complications راح تشوف مثلا coronary artery disease, kidney disease, and then you will have healing disorders اللي هم منهم diabetic foot, as well as مثلا more likely to have stroke, more likely to have كل هدول الأشياء that are due to vascular compromise in diabetes due to the accelerated atherosclerosis and vessel disease. تمام. هاي الأولى. هلا neuropathy is now they have reduced sensation خاصة بالlower extremities at the distal lower extremities بالfoot, فبتلاقي عندهم more likely to have مثلا trauma that is unnoticed, and that's basically the most important thing. عدا عن هيك ممكن they might have مثلا gait disorder يعني difficulty يعني I don't want to say gait disorder, it's not really a cerebellar disorder, but they might have proprioception. They don't feel well, their surroundings very well if the neuropathy is advanced. So so this is vascular, neural, and then you have an immune problem with diabetes. Immune problem حكينا hyperglycemia leads to poor immune function and wound healing. Other factors بحكي لك مثلا poor vision, limited mobility, previous amputation. هدول because of the hyperglycemia can have effects on proteins. So certain proteins in the setting of hyperglycemia will become their structure might change, which can change the proteins, and مثلا it can cause مثلا cataract. Good ناس عندهم diabetes, so over time the hyperglycemia will change the protein structure الموجود بالعين, in the cornea, and then in the lens, and then over time they will start seeing opacification and the lens has to be changed. So these are the risk factors that we see. So diabetic foot is a common complication. They often carry a very high burden of morbidity, and they are notoriously difficult to manage. في حتى شو بيسموهم diabetic foot clinics, أشياء فقط للdiabetic foot to monitor this. So أكثر أشياء بتشوفها بالdiabetes, diabetic foot, eye problems, and obviously heart and kidney problems. تمام. So risk factors هلا هم حكيناهم neural, so development of peripheral sensory motor and or autonomic حكيناهم. neuro osteopathic deformity مثلا charcot joint شوفوها هدول بعدين. vascular حكينا vascular insufficiency, we mentioned how that works, and then immune حكينا how that works, and then other factors اللي هو نفسه المريض رح يكون عنده حكينا مثلا proprioception is different, limited mobility, رح يكون كبير بالعمر, ممكن previous amputations, poor health care, الفيجن حكينا بصير affected. all of these وما بحس برجليه, all of these can increase the chance of having trauma in the foot, which might be unnoticed, which might get infected, which is not very well controlled by the immune system, not very well perfused, فما بدخلش الاميون سيستم جوا. كله هذا على بعضه is a syndrome. So etiology of diabetic foot infection. So what are the organisms that here we're going to look at? فمن فوق لتحت are probably the most that you will see. Cellulitis, again the same representatives الموجودة بالحكيناهم بالبداية are the same. So group A, C and G, and then group B طبعا أهم وحدة اللي هم group A strep, and then C and G and then B. Then ما بدي تحفظ الأوردر, بس إنه يعني group A probably the most dominant one. But the other species are more seen in the setting of diabetes, then staph as well. هلا في عندي إشي اسمه أنا infected ulcer antibiotic naive. شو يعني antibiotic naive؟ naive يعني ساذج. So that means this ulcer has never, يعني واحد مثلا صغير بالعمر ما عمره شاف شغل بحياته, he's naive, he never seen it before. So that's what it is. It's an ulcer that has never been treated with antimicrobials before. This is good. So an infected ulcer that has never been treated before, other than the beginning ulcer, the first ulcer that this patient ever had, will often be monomicrobial, and then will have the same organisms that we saw in cellulitis. So staph and beta hemolytic streptococci. And then an infected ulcer. Now this is not a naive ulcer. هذه عندها خبرة, شافت الأمور, شافت الانتيبيوتكس, هذول البكتيريا شافوا الانتيبيوتكس. So once I have treated this ulcer, now I change the makeup of organisms. هاي رقم واحد بالسكن بهاي المنطقة in the foot. رقم واحد. رقم اثنين, هذا المريض بالغالب دخل المستشفى. بما انه دخل المستشفى تعرض لهاي الألسر, تعرضت للبكتيريا جوا المستشفى. شو هم اكثر شيء بنخاف منهم؟ enterobacteriaceae. So اللي هم enteric bacteria, E. coli, Klebsiella, whatever that you might find. And this ulcer will be usually polymicrobial. شو يعني؟ مش بس هاي or high, all of them together at the same time. So this one, obviously an infected ulcer, which is chronic with previous antibiotic therapy, would definitely be more difficult to manage than a naive ulcer. A macerated ulcer will probably be an infected ulcer now that has صار فيها تهتك. So now the surrounding tissue becomes macerated, and this is where you can see Pseudomonas. This is typical presentation of the entry of Pseudomonas into the ulcer. Again, this is more likely to happen in a nosocomial setting. بعدين في عندي long standing non-healing wound, prolonged antibiotic therapy. This is an upgraded problem than this one, this problem here. In this case, I treated it, خفت ورجعت خفت ورجعت خفت ورجعت. So this is a long standing non-healing, it never healed fully, with prolonged antibiotic therapy. فهاي البكتيريا قاعدة شو بصير فيها؟ there is reduced perfusion للألسر. معناته there is subacute suboptimal levels of antibiotics entering the wound. إذا أنت بدك عندك مريض، يعني أنا بحكيها بطريقة يعني هيك شوي مضحكة. عندك مريض وأنت بدك تعمل عنده antibiotic resistance، بدك تضره أنت. شو بتساوي؟ بتروح تعطيه جرعة antibiotic أقل من الجرعة المطلوبة، مثلا 500 مايكروغرام will kill this bacteria. روح ضلك أعطيه 300. He will have resistance. Why? Because you are giving sublethal doses to the bacteria. The bacteria that are dying من 300 البقية بضلوا موجودين. هذول they will have more chance to regroup and then grow again. So they will face the antibiotic again and they will grow again وهكذا سجال إلى أن one of them has the chance now, because you have not completely obliterated them, one of them will have the chance to grow. زي ما حكينا بالبكتيريا. I'm not worried about يعني البكتيريا, you don't worry about إنه أنا بدي أقلل عدد البكتيريا. So if مثلا هاي الألسر فياتها 20 مليار خلية, which is not true, 20 مليار خلية أنت قتلتهم كلياتهم, خليت واحدة بس, ضل واحدة صارت resistant, happened to be resistant. Is that good? No, because in one day this one resistant cell will become the dominant, will become a parent of all the cells. So in a couple of days you will go back to the original number, but now all the cells are now resistant. So suboptimal doses of antimicrobials are damaging. So عشان هيك احنا طبعا ليش خلينا معناته هيك خلينا من هون طالع اعطيه زياده. What is preventing me from giving the patient زياده? Toxicity. The patient can't tolerate the doses of high. فعشان هيك احنا عندنا الoptimal dose اللي هو الموجود. هلا any wound that has reduced perfusion will, حتى لو انت اعطيت الدوز المضبوطه اللي بتحملها البيشنت بحسب الكدني والليفر, it is not sending enough antimicrobials into the wound. فهدول this happens in a setting of a long-standing, non-healing, prolonged antibiotic therapy wound. In the setting of diabetes هذا صارت أسوأ وأسوأ. So this is what usually would be what? A polymicrobial, any of these that we mentioned here. Now I have added the issue of antibiotic resistance. So now I have antibiotic resistant polymicrobial infected diabetic foot ulcer. So كلهم staph aureus, coagulase negative staph, enterococci, diphtheroids, anaerobes, enterobacteriaceae, pseudomonas, non-fermentive gram negative rods, fungi, كل شيء يعني أبدا. Fetid foot is يعني now this is gangrene, necrosis and gangrene. So شو في عندي بالنecrosis الجانجرين اللي حكيناها بالمحاضرة الماضية in the flesh-eating bacteria and necrotizing fasciitis. Necrosis is not reduced blood, is stoppage of blood. But there is no entry of blood at all, which you will cause irreversible cell injury زي ما حكاكم دكتور موسى. And then you will have what? Gangrene. That happens in the case مين بدخل حكينا بالجانجرين obligate anaerobe. So this is what I will see in fetid foot or gangrene or necrosis. فهذا هو صار عندنا القصة. So mixed aerobic gram positive حكيناهم هذا. So you have the aerobes, facultative anaerobes, which then pave the way for tissue destruction, which then will introduce the obligate anaerobes. تمام. هاي أهم جزء، أهم يعني this table هاي موجودة بشو اسمه بأكسفورد. So this vascular foot breakdown, this is a non-open lesion, and then a superficial ulcer which will open up to make a deep ulcer. Then you start seeing the underlying tissues and fascia, and then you will start seeing an abscess osteitis. So now the ulcer has, in grade 3, has been upgraded to the bone. Gangrenous forefoot. Now the forefoot has gangrene and the entire foot. This is grade 5 with the entire foot becoming gangrenous. Diabetic foot ulcer شو بتشوف عليها دائما usually the sites of pressure are more likely to be hit. فبتلاقي دائما مثلا wherever pressure occurs is usually where the ulcer happens. ليش؟ يعني this is the area where it requires remodeling. فممكن with extenuous use وانت هذه المنطقة اللي بتدعس عليها أكثر, so it's more likely to encounter trauma. فهاي diabetes حكيناهم: motor neuropathy, foot deformity, sensory neuropathy, autonomic neuropathy, dry skin, decreased sweating, loss of protective sensation, biomechanical abnormalities, كلهم بدخلوا. You might have a callus formation, and then subcutaneous hemorrhage, repetitive external minor trauma, peripheral artery disease. كل هذا اللي حكينا will then result in a foot ulcer. هذا المريض نفس المريض هنا is this patient. هذا المريض I think this is New England Journal. Yes. فهذا المريض he was diabetic. شو الفرق بين هاي الفوت وهاي الفوت؟ هون هو يعني هاي the more close to normal وهون شوفي it's darker, right? And it's thinner. The patient probably lost weight, صار يتعرض للشمس أكتر, صار يتحرك أكتر. So he controlled his blood sugar. So what happened when he was not controlling his blood sugar? So he had this infection which he kept monitoring every day and taking pictures of it. And this is how it kept getting worse and worse. قاعدين نشوف من necrosis والinduration وهالحكي كله. And then this is the ulcer after it healed, after management and healing. هذه كان هو, he was lucky. This was a naive ulcer. يعني with antimicrobial therapy the infection resolved, and then probably with some debridement or something. I don't know if they did debridement. ما بعرف. المهم probably they did. At least وشايفين هنا there's مثلا fibrosis, so and a scar formation. So the patient lost considerable amount of weight. He controlled his blood sugar. صار عنده blisters, necrotizing abscess. He had, yes, he did have debridement, surgery, debridement, and everything. Treated for antibiotics for 3 weeks. Infection resolved. So what is the main, فمن هاي السلايد شو بنحكي انتو اذا عندك واحد مريض عنده diabetic foot? What is the optimal, the mainstay for treatment, for therapy? Is blood sugar control. You control blood sugar, you control the infection. So if the blood sugar is controlled, you will have much better outcomes and probably less likely to have diabetic foot. So اللي احنا بنعمله of culture and sensitivity and then treatment and then هذا كله in the setting of a patient who is not well controlled بالعادة. So this is the glycated هو A1C كتير عالي 10.5. يعني the ideal is around less than 5 or 5.5. تمام. So clinical features range from mild, severe, life-threatening as the following: foot ulcer with no signs, foot ulcer with surrounding inflammation, cellulitis. زي ما حكينا بالتيبل بتصير cellulitis with local complications, beneath the superficial fascia, deep tissues, abscess, gangrene, muscle, tendon, bone. حكيناهم هذا كله. And then you will have systemic toxicity or metabolic instability, which will require treatment. fever, tachycardia, كله هذا حكينا، leukocytosis, acidosis, hyperglycemia, uremia، كله هذا complications of the blood sugar problem. And then with the infection. Diagnosis ما بدها شطارة. Clinical features. So you must assess perfusion. You can assess the pulses. هل بتحس بالبلس اللي موجود ولا لا؟ بالarterial pulse obviously. So if you can feel it, then the better that you can feel it, the more that is likely to have better outcome. You can do Doppler ultrasound. You can see the how well it is perfused, and then peripheral pulses, less perfusion, more anaerobes, as well as sensation. Use a monofilament. استخدم monofilament زي هيك شعيرة بلاستيكية, and then you can use it. This is used for يعني assessing neuropathy and sensation. تعملوا شغلة سنة رابعة. دوبلر حكيناها. imaging MRI. شو بدك تشوف هنا؟ the extent of infection. إذا عملت MRI بدك تشوف إذا في عنده osteomyelitis, fasciitis. So this can لما نحكي عن osteomyelitis, this can become a seed for continued infection in the foot. فإذا الفوت صارت كبرت الألسر وصلت للبون. Now if it enters the bone, osteomyelitis is a much more chronic problem than soft tissue problem. So this might become much harder to treat. فتخيل انت the reduced perfusion للسكين راح يكون لسه أقل وأقل على البون. But this is one of the issues here in the setting of diabetes. Deep tissue specimens, no superficial swabs. You need to be sent to our lab for microscopy and culture before antibiotic treatment. Management. Inpatient versus outpatient. So an inpatient, based on correcting system instability, حكينا medical treatment. You do not give antibiotics for non-infected ulcers. هذه كثير مهمة. So initial infected ulcer, you need to empiric therapy, مثلا oral for mild cases and IV broad spectrum for severe cases, and then and then surgery, severe infections in deeper tissues, necrotizing, كل هذول حكيناهم. Wound care plan following discharge. تمام. هيك خلصنا احنا diabetic foot. Now we're going to cover the rest of the lesions in the skin. عشان المحاضرة الجاي نحكي عن bone and then the muscle. So papular and nodular lesions. Papular and nodular lesions. We're going to cover many of them, and you can see here you have from bacteria to certain viruses. So it is a heterogeneous group of microorganisms. Let's go through them. So Mycobacterium marinum, infection of the skin, may present as cellulitis or as raised erythematous nodules. This is an occupational hazard. So من الهيستوري حكينا, usually for aquarium cleaners, fishermen, seafood handlers. Organism growth requires low temperature. So a lower temperature will probably be in the upper layer of the skin. So it will not be 37, which is the core temperature of the body. فأنت مش كلك 37 degrees. Your core temperature is 37. عشان هيك لما يجي نقيس الحرارة بتحطها مثلا جوا الفم، بتحطها بالأذن، تحط الثرمومتر مثلا تحت الإبط. يعني all these ways so you can measure the core temperature. بالسكن مثلا راح تكون بالإيدين distal limbs. It will probably be less. النوز حوالين النوز بتكون أقل. So this organism would have a better growth at that temperature. Diagnosis: needle aspiration. You can see acid-fast bacilli with a ZN stain or whatever stain you want to use. Rifampin, ethambutol for 4 months. This is your antimicrobial, microbacterial therapy. So this is what it looks like. You can obviously history is the your main helper in this in discovering this. Cat scratch, Bartonella Hensley. This is a gram-negative rod. Usually grows on Columbia agar, supplemented with 5% sheep blood. The transmission cycle is between cat and flea. Then the cat transmits it to a human by bite or scratch. So between cat and flea, so it is less likely that a home cat, which is well taken care of, نظيفة ما عليها fleas, is less likely to have it. يعني إذا ممكن تلعب أكثر واحد مثلا بيلعب مع بسس برا أو جاب بس من برا more likely to have been through the cycle of cat and flea this cat will then scratch the human and then transmit this bug. Symptoms بالبداية راح ممكن عندهم myalgia, arthralgia, malaise, anorexia, maybe even low-grade fever. Signs: the lesion is papule, pustule, or a large vesicle, and then developing at the primary site of inoculation محل ما انجرح. Then in an overwhelming majority of cases they will have persistent, painful, regional, ipsilateral lymphadenopathy. So lymphadenopathy, which is painful, would be painful only on the side of the scratch. A diagnosis: you can do serology. You can check for the antibody titers. تعمل titers وتشوف إذا بدور على titers لهذا الانتيجين for this bacteria. Or you can do biopsy of the lymph node, which is probably but more invasive. Treatment in immunocompetent patients: this is self-limited, so this is not an issue. It resolves within 8 weeks, and there's an increased risk of reaction if antibiotic given within the first 48 hours. Bartonella Hensley is a bigger problem, cat scratch disease, in immunocompromised patients. So this is what we're talking about. Cat flea cycle. The cat has it, scratches a human. This is an incidental host. This is an immunocompetent patient. We have this ipsilateral lymph node, which might be painful. Will resolve on its own. Some guidelines indicate that you can give antimicrobials to it. فراح تشوفوا لقدام إنه مثلا you might learn something in certain مثلا مع دكتور معين بتحكي نفس الشيء هذا حكى لك يا دكتور لدكتور ثاني بيحكي لك لا هذا غلط. Why? So the main issue is خاصة عندنا بدولنا إنه we have people that train in different countries. فالguidelines بإنجلند مثلا nice guidelines have different guidelines. مثلا American guidelines are different, German guidelines. فكله all of these work. Sometimes that's why بتلاقي مثلا بيحكي لك ممكن ناس بيعطوا هيك ممكن ناس بيعطوا هيك because of the difference of guidelines و different sources. إذا أخذت كتاب أمريكي ولا كتاب بريطاني ولا كتاب من journal معينة things can change in certain guidelines. المهم في ناس بيعطوا antimicrobials في ناس ما بيعطوا antimicrobials, but بالنهاية that we can agree on is cat scratch disease in immune competent person is not serious and can resolve on its own. هلا in an immune compromised person, this is will give you bacillary angiomatosis, which is an advanced disease and can give you severe skin reaction and is definitely requires treatment. Schistosoma, parasitic blood flu, multiple erythematous papules develop in schistosomiasis. Each represents as a cercaria invasion site. So this is يسموه بالهارسيا. Acute phase of this is Katayama fever, which is a whole body hypersensitivity fever with malaise. تذكروا حكيناهم skin size who can swimmer's itch, we mentioned that. The addition here that I would like to mention إنه بالهارسيا has been a big problem بدولنا خاصة في مصر, where lots of أطفال بيلعبوا بسموها الترعة اللي هي بتكون مثلا collect a body of water, a small body of water that is does not have any tributaries, so بتكون مية ساكنة مية راكدة. So we'll have growth of these بتكون obviously infected زي ما حكينا, and then kids play in them and then they get these schistosomias, and then over time if left untreated over time لما يكبروا بالعمر بتلاقي يصير they might have liver problem, liver failure, many diseases. فصار عندهم يعني big health notice إنه ما تلعبوا بالتراع وافحص الشيستوسوميا أو شو, because the treatment بالبداية is very easy. So you can give a single dose praziquantel, which is anti-parasite, and then you can kill the parasite. So ما في شيء جديد. snail, sporocyte, again يعني nothing that we haven't mentioned. Okay, so we can migrate to the portal blood and then go to the mesenteric venules of the bowel rectum and shed in the stools, and then again back into the water. Liver problem, colon, all of that. So what we want to worry about is the skin manifestations of this disease. Schistosomiasis وين موجود أكثر شيء بأفريقيا. You can see بين خاصة South and Middle Africa. مصر, السعودية واليمن has probably دول عربية والسودان probably the more having the higher prevalence. Prognosis, early disease usually improves with treatment. عشان هيك هنا if you can catch it early that is fine. More advanced stages with hepatic and urinary disease improve following a long-term therapy for months or years. Even if fibrosis occur, renal intestinal pathology also improves with treatment. حتى لو صار عندهم pathology بال renal or intestine or the liver might improve if you treat the cause. As usually do brain lesions depending on their location. Hepatosplenic schistosomiasis carries a relatively good prognosis because hepatic function is preserved until the end of the disease. إذا بتسمعوا عن ممثل اسمه أحمد زكي رحمة الله عليه بتعرفوه يعني من المسرحيات القديمة, هي وكمان عبد الحليم حافظ I think as well. هذول both of them had I think one of the main causes of their death was due to schistosoma bilharzia. Leprosy اللي هي mycobacteria. So this is a mycobacteria, again requires less temperature, so it lives in the skin nodules. بس هذا has a very long incubation period. It takes years to develop. So leprosy is caused by Mycobacterium leprae. Chronic infection of the skin causes granulomas at the body, which aims to contain the bacilli زي الجرانيولوما اللي راح تكون باللنج بالتي بي, because so you want to control the bacilli. Transmission mostly by nasal secretions of untreated patients. However, low risk from casual contact. You want عادة بيحكي لك more intimate prolonged contact will carry higher risk of transmission. Has two types. Tuberculoid, the patient has intact immunity, usually never changes, and this is predominant. And then you have the second type, which is lepromatous leprosy, which is much worse, where skin changes predominate, where these patients have a defect in cell immunity. فعادة بنشوف إنه إذا المريض has good cell immunity, will probably have the first type. If they have worse cell immunity, will have the second type, and more likely to progress into lepromatous leprosy. Skin changes will have bilateral symmetrical macules and papules, which progress to nodules and even plaques. Usually hyperpigmented in dark-skinned people, seen on the face, wrists, buttocks, knees, sparse groin, axilla, folded skin, which has higher temperature, which doesn't favor the growth. Diagnosis: acid fast stain, skin smears, and biopsy again. Antimicrobacterial drugs, dapsone, rifampin. Dapsone, this is unique leprosy. Treatment at early stages for about 1 to 2 years, and leprosy treatment may be lifelong. هيو طلع عليها مثلا هذا طلع على الحج, ممكن تطلع عليه تحكي مثلا يعني شو ماله الحج, شو بدك, شو مالك عليه. This is actually, he has leprosy actually. So the thing is إنه مثلا واحد بيكبر بالعمر, you have symmetrical changes in the skin, folding وتجاعيد وهذا, so it might go unnoticed. But if you have a good picture of that patient in مثلا قبل 5 سنين أو 10 سنين, it might indicate إنه مثلا this is not going to progress as this bad. But now look at lepromatous leprosy. This is يعني quite severe as you can see. Syphilis. شو السكين changes اللي بنشوفها بالsyphilis. So large nodules or gummas are feature of tertiary syphilis, which is the late untreated syphilis. طبعا هذا مش راح worry about probably the tabes dorsalis or neurological problems is probably more worrisome at that point. But flat احنا بنطلع عليهم skin lesions. Flat papillosquamous lesions are characteristic of secondary syphilis. So 33 to 90 days after exposure to مثلا sore, the rash, and about stage 2, and then stage 3 will have through the internal organs. So this is what we're going to talk about. Primary syphilis. The chancre is at the site of infection, عادة مثلا penis. So that is one skin change that you can see where treponemas will grow. Secondary syphilis, papillosquamous dermatosis all over the skin, and then condyloma lata, which is painless wart-like lesions around the anal region. So secondary syphilis, papillosquamous dermatosis, condyloma lata. Condyloma acuminata is also around the anus, but due to viral illness مثلا HPV هلا رح نحكي عنها. So هنا نروح نحكي عن ال HPV. HPV may cause singular warts. HPV حكينا عنه احنا بنخاف عليه بنشوف من ايش اللي بخوف اللي هم HPV as an STD which can cause cervical cancer. الارقام العاليه 16 ل 30 هذول الارقام بتعمل. الارقام الواطيه are more common and do not have a risk of cervical cancer. So may cause singular warts, verruca vulgaris, or multiple warts in anogenital region. هاي condyloma acuminata, which is a major problem in HIV patients. بحبوا أحيانا بيستخدموها امتحانات الخارجية to mention مثلا they have whatever skin problem around the anus. So you can say, oh, with his condyloma acuminata, he might have warts, he might have advanced disease of مثلا HIV or something. So this might be your only clue بالسؤال إنه this patient has HIV. So verruca vulgaris in common children and young adults, transmitted by skin contact, sharing certain tools, cloth, usually on the hands, nail edges, or auto-inoculated to yourself. مع إيش معناته محل يعني whatever you're using يعني أصابعك إيديك. So nail edges, wherever contact with the tools and the cloth and the people might have it. Management على الدرمة بدوهم على الدرمة زي ما حكينا. Liquid nitrogen or something, they might have plenty of ways to deal with HPV. So digital, this is HPV, this is someone who auto-inoculated themselves, and this is condyloma acuminata. So هلا خلينا نجمع كل الأشياء تبعين السكن مع بعض so as to have sort of a mind map to attack any problem where you can see when someone has a skin infection. So as discussed, so far diagnosis of skin infections depends on three main clinical observations. أول شيء appearance of the lesion حكينا بدي أشوف هي macule, papule, vesicle وين. رقم 2 بدي أشوف عليها هي وين location within the layers of the skin. Is it on top? This is stratum corneum, epidermis, willodermis, and then where in the relative to the body, trunk versus face versus extremities. So aiding information that helps fine tune هذا يعني صار عندك الفكرة الأولى, and then you want to fine tune your input data. So the temporal progression of the lesion, وين بلش طلع زيادة صار مثلا appears in crops, appears acutely مثلا, patient's history, عنده travel history ولا لا, عنده pets ولا لا, عنده animals ولا لا, قديش عمره, السكس ممكن حكينا might have things, sexual contact مش بس يعني sex as in gender, and then sexual contact as well, underlying diseases, عنده شو عنده underlying disease, and his lifestyle as well. So however, even the most experienced clinician will find it difficult to diagnose all infections of the skin and soft tissue by history and inspection alone. يعني قد ما تكون شاطر, again you might have راح تعمل لستة عندك انت، مثلا رقم 1 ممكن يكون هيك، رقم 2 ممكن تكون هيك، رقم 3 ممكن تكون هيك. But you do not have your definitive diagnosis sometimes. So ممكن انت مثلا اذا كان 70% رقم 1 عندك differential رقم 1، there is a 20% chance مثلا رقم 2 او 10% لرقم 3. You might be wrong and you might treat it as number 1, which is 70%, and then it might come up to be your second or third differential, right? So this is where you want to acquire more data. So soft tissue radiographs ممكن تعمل CT, MRI may be used to help determine the depth of infection. This helps you assessing the deeper infection. مثلا you might recall مثلا serious ones مثل fasciitis rapidly progressing are more deep. Evidence of a systemic inflammatory response syndrome مثلا to find local infection and maybe releasing toxins مثلا. كمان شيء ثاني ممكن يعطيك هلا هدول radiographs and defining a localized abscess or detecting gas in the tissue. تذكروا كمان حكيناهم where anaerobes are present as well. So this is a CT scan of someone with necrotizing fasciitis and then myonecrosis caused by group A strep. So it is a very good practice for you انه خاصة بهذا الموديول انك تتعلم الستركتشرز على السي تي. Probably the overwhelming majority of questions that come up in exams, whether it's USMLE or PLAB or لقدام شوية كمان they will ask you about CT scans. بيطلبوا يجوك CT عشان تلاقي structures انت بدك اياهم بالسي تي. فهون ليش بنطلع مثلا this is very easy. عادة امسك السباين تحرك منه مثلا. You can see مثلا descending aorta. This is probably pulmonary artery, lungs. Here you can see the anterior chest wall, sternum, وهكذا. So what do we have here? You can see طلع على both sides. One side is swollen with deeper tissue here showing necrosis, and this is inflammation of the left chest wall, as we can see here, and patient with necrotizing fasciitis and myonecrosis caused by group A strep. تمام. Lab aspiration. So without saline is better, less dilution. If you inject saline to take in more to capture more bacteria or more organisms, you're likely to dilute it and reduce the number that you capture. Punch biopsy or frozen section might help if imaging is positive. However, there is a large false negative rate. Frozen sections are especially useful. مثلا إذا بدك تعرف هل this is مثلا Staphylococcus skin syndrome or TEN. So if you do a frozen section, you can tell on which site in the skin is where the bullae are formed. So this is quite valuable as well. Open surgical inspection plus debridement is the optimal way to determine the extent and severity of infection. Also, this is the superior method to obtain specimen for culture and gram stain, which will ultimately also give you a sensitivity profile, so you can, which will help give you the optimal antimicrobial therapy. Surgical approach may be an aggressive approach. It is an important step and might be life-saving. Treatment overview. So furuncles, carbuncles, abscesses caused by MRSA and sensitive strains are commonly encountered. Again, a treatment here, you can مثلا furuncle can treat with moist heat. إذا كان كبير مثلا surgical drainage. Drainage antibiotic إذا كان larger and larger with systemic problem. So مثلا study where it shows children who showed that surgical drainage of abscesses was as effective when used alone as when combined with antimicrobial therapy. So drainage alone was enough. However, recurrence was less in groups that added antibiotic with the incision drainage. عشان تخلف معناته أنا إذا بستخدم antimicrobials I'm not really treating, I'm reducing recurrence. So I will still use antimicrobials, but now I know why I'm using antimicrobials. So what are the treatment of the common infections of the skin؟ مثلا animal bite، شو حكينا عنهم هذول. So you want to give amoxicillin with clavulanic acid with the alternative treatment to being doxycycline. Animal bite, you have an established infection, ampicillin with sulbactam. Alternative treatment, clindamycin plus cipro or cefoxitin. bacillus angiomatosis، ذاك المريض شو بعطيه أنا؟ erythromycin. doxycycline is your secondary alternative treatment. herpes, genital herpes حكينا acyclovir. And we have the حكينا alternatives: herpes zoster, acyclovir. Cellulitis, the anti-staph, and then your other options were cefazolin, if you recall. MRSA, vancomycin, linezolid حكيناهم. Necrotizing fasciitis, so clindamycin plus penicillin. And then we mentioned the other ones. Necrotizing fasciitis الanaerobes كانوا ampicillin, clindamycin, ciprofloxacin. So you're covering gram positive, gram negative, anaerobe. Cas gangrene, anaerobes plus penicillin for the cell wall. تمام. تمام. I think we'll stop here. This will be part of the last lecture. المحاضرة القادمة we'll go through the bone infections, and then we'll continue the muscle infections. Okay, يعطيكم العافية.